Jack West, MD. I'm an associate clinical professor in medical oncology at City of Hope Cancer Center in the Los Angeles area, and also founder and president of GRACE. Isabel, can you tell us who you are and what you want?
Sure. My name is Isabel Preeshagul. I am a thoracic oncologist at Memorial Sloan Kettering, and I am very excited to be here today speaking to all of you.
And Joan.
Yes. Hi, everyone. I'm Joan Schiller. I'm a medical oncologist living now in Northern Virginia. I was formerly the deputy director of the Cancer Center at UT Southwestern and also of the Shar Cancer Center in Northern Virginia as part of Inova.
Excellent.
So glad to be with you.
Circulating tumor DNA is a hot topic. We've already alluded to in some other settings how you can send off a blood test and find potentially mutations like EGFR and ALK, and with faster turnaround than you can find for sending off tissue, which can take 3 or 4 weeks. But there was an interesting study at ASCO from the UK looking at patients who had undergone potentially curative surgery or chemo and radiation, and essentially found that the patients who had detectable circulating tumor DNA after treatment had a much worse chance of going without relapse and were far more likely to have died. And that was true whether it was with chemo, radiation, or surgery. And there were a few other studies that looked at targeted therapies like lorlatinib for ALK positive, and in another setting, tepotinib for MET positive disease, and just showing that patients who had a rapid drop in the circulating tumor DNA within weeks of starting these treatments were the ones highly likely to go far longer without progression. And so at this point, it's not a standard treatment, but my question is, how optimistic are you, and do you see this as being a pivotal part of how we interpret and use, assess disease for who's at risk and needs postoperative treatment, who should switch to a different targeted therapy after 4 weeks? Is this something that's coming in the next few years? Joan, can I start with you?
Yeah, I think those are really good questions, Jack. The problem, so first of all, from a biological standpoint, it's really interesting that you're able to get this type of data, circulating tumor DNA. And it is certainly open for a lot of other scientific studies. But right now, most of it is just documenting what you're going to find out anyway, simultaneously, right? I mean, you get another blood level at 6 weeks, well, you're getting a CAT scan at 6 weeks. Anyway, it doesn't change what you do, unfortunately. It's not even really helpful in terms of telling you whether if someone's got at this point in time, hopefully we'll get those answers, but if someone starts out with high circulating tumor DNA versus someone who starts out with low circulating tumor DNA, do you do anything differently? Right. I mean, I think we don't know. Hopefully we'll get those answers. But
so right now the challenge is it may be helpful to delineate who's going to do better or worse, but until or unless you can do something about that to change the trajectory, you're limited. Isabel, what's your view? And, do you think this is going to find its way into clinical practice routinely?
So I actually am very interested in this area, and there's a couple protocols that I know. We have one also at Memorial that's looking at patients with an EGFR mutation. And if it's detected in your plasma at diagnosis, then at 6 weeks, if it's still detected in your plasma after 6 weeks of osimertinib, you would get OC plus chemo. And if it's not detected, then you come off the study. So I'm curious to see if those patients that still have ctDNA detectable or their EGFR mutation detectable at 6 weeks after 6 weeks of OC, if it's an indication that they have perhaps a more aggressive disease and need OC plus. So I'm waiting on that data. And I'm very excited and interested in that study. And I'm really curious to see if there's something more we can offer these patients and kind of usurp any resistance alteration that may happen.
That's great. Well, I think you bring up great points about not being irrationally exuberant, but still being hopeful. I think the biology, I've been impressed that while these have been small studies and they haven't changed, anything prospectively yet, not just in lung cancer, but in so many other types of cancer, they're so consistent that has struck me as an indicator that they've been pretty reliable in what they tell you. We just need to figure out how to incorporate them and clarify whether you can alter the trajectory or whether it's just irreversible.